Good evening, everybody. Welcome to this BTOG webinar on updates from World Lung and ESMO 2022. Thank you very much for joining us. A little bit of the usual background bits and pieces. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital in London, and I'm the vice chair of BTOG. First thing to say is BTOG is sponsored, but the sponsors of BTOG events don't have any role whatsoever in the planning, content or delivery of anything discussed today. But that being said, we are grateful for the support of our sponsors this evening. So, as I say, welcome from everyone, and thank you again for joining us. We do appreciate we had to change the date of this webinar from last Monday, which was of course a Queen's funeral, to today, so thank you for making additional time in your diaries to join us. Regarding BTOG, as you know, the people who run the show really are Dawn and Gina. If you'd like to know anything about BTOG, please contact them on the email or web address here. And if you're not a member, why aren't you a member, then please do join up. We would love you to be part of our organization. So a couple of housekeeping. We really enjoy the questions. I think they're actually the best part of the whole thing, with the greatest respect to my various speakers. So please do put questions in. You can do that on the panel through your web browser. You can do it with your name attached if you're feeling brave, or you can do it anonymously if you're feeling shy. And we're going to have 15 minutes at the end for questions and discussions. You can get CPD points for your RCP diary. You've got the approval code there, and you've got up to 4 weeks to do that. But we please ask you to send us your feedback. We want to constantly improve the educational content we provide you guys from BTOG. So all your comments and feedback is greatly appreciated. Right, so let's get on with it. We're going to be talking about an update from World Lung and ESMO this year. World Lung was in Austria in August, and ESMO was in Paris just 2 weeks ago. I'm joined by three superb speakers and myself, and we're going to go through screening for lung cancer, starting with Professor David Baldwin, moving on to surgery for lung cancer and other thoracic malignancies with David Waller, then on to early stage non-small cell lung cancer with Yvonne Summers, and then I'm going to finally wrap up with a metastatic. We're going to have a chat, and we'll all be done and dusted by 6:30. And you may be saying, but hang on, it said ESMO and World Lung in an hour. That's an hour and 15 minutes, but that's inflation for you. For those of you disappointed that I'm not Sanjay Popat, unfortunately Sanjay was not able to make today's one, which is why you have me both as a chair and a speaker. I'm very sorry about that. So without any further ado, I think we will move on to our talk about screening with David Baldwin. So Professor Baldwin is a respiratory physician at the university's hospitals in Nottingham. He does a huge number of other roles. He's a friend of BTOG. If I went on about his other roles, we'd be here for the whole evening. So instead of doing that, I'm going to move straight on and ask David to take us through the updates on screening from World Lung and from ESMO this year. David, thank you very much for joining us.
Well, thank you very much, and delighted to be involved with yet another BTOG webinar, and really looking forward to the meeting in April when we're meeting face to face. So I'm going to talk primarily about the World Lung Cancer Conference. Just unfortunately, I wasn't able to attend ESMO, and in fact, the screening activity in World Lung is always very complicated and detailed. We had a screening workshop which was run on the Friday, and normally the screening workshop is a little bit of a sort of same-ish topic type workshop where the same things are discussed pretty much every time, and then they tend to then go through the whole program, and this has sort of been criticized as a rather repetitive. So on this occasion we were tasked with the difficult process of trying to get a completely unique program which didn't really cover a lot of the things that were done in the main program. We didn't achieve that, but the comment from the reviewer at the end of the day was that the majority of topics discussed today, that's on the Friday, are innovative concepts which are in development. So that was really good. So I'm going to just go through one or two of the things, the highlights of that screening workshop, which was a closed workshop. So quite good to be able to spread that about a bit. The The first thing is the description of a new program. I'm just going to mention this as a sort of really get people thinking, and then something about quality assurance and technology. There's a section on personalized risk assessment and also diagnostic workup, including incidental findings. The firstly then dealing with the Taiwan lung cancer screening in never smoker trial, the TALENT trial. And as you can see, the inclusion criteria there, usual sort of age range of 55 to 75, but never smoking people who had got one or other of these risk factors, a major risk factor being family history of lung cancer, but also environmental tobacco smoking history, any chronic lung disease, and this concept of a cooking index, which is a feature of how long people are exposed to potentially fumes from cooking. And they had to have a negative chest x-ray as well. And this was these were the sort of top line results. Firstly, of their 12,000 cases, 313 were T0 lung cancers. That is to say, not invasive adenocarcinomas. So, interestingly, the way they define this, and this can be a feature of a number of screening projects that are come from Eastern Asia, where you have quite a few people that have included in their lung cancer rate this T0 stage, which is, as you can see, adenocarcinoma in situ in 58 of the total number of lung cancers there in terms of the detection. So we have a sort of issue here that potential overdiagnosis is occurring, and we're not completely sure. I'm not completely sure yet as to what the whole truth of this is, because there are some other data coming from Taiwan suggesting that the mortality rate has not improved, which is of course the way we measure the impact of CT screening. These were the conclusions from the take-home messages from the presentation. And a very, very high lung cancer detection rate, 96.5%, 0 to 1. Lung cancer family history being an important risk factor for development of lung cancer and selecting people for screening. And the plans for going ahead with a nationwide low-dose CT screening study, both for heavy smokers in the conventional way, but also never smokers with risk factors, particularly lung cancer. So sorry, particularly the family history. Very interesting, but we just need to watch carefully as to what the overall results will be. QA and technology is a really big thing now. It is a developing area. And there are quite a few presentations, both in the main symposia, but also on the CT screening workshop, about how one incorporates a variety of different assistance to the reporting process, and also how one uses artificial intelligence in interpretation of the results. So it's both detection, which is something like computer-aided detection of nodules in widespread use now, and how that interacts with behavior of the radiologists when they're reporting, but also AI interpretation of nodules, predicting risk and predicting future risk. We also heard about a number of things that are looking at the QA of radiologists in particular, and our own program, the Perfect program, which is based on a very similar system to that used in breast cancer screening, was also presented and generated quite a lot of discussion. And then interestingly, from the ISLC LCAP group, there was this education resource that was presented, which is more about, in fact, trying to make sure that the workup, the downstream workup, is improved by providing example cases, which I thought was very interesting coming from the US, as we know that there have been some criticisms about how much further investigation is done in some of the US screening studies. There's then a lot of discussion about personalized risk, using the baseline scan to define the future risk and then tailor these screening intervals according to that risk, using blood biomarkers with the low-dose CT and machine learning approaches to defining CT interval, all very much theoretical. In the general sessions, there was one very interesting study, I thought, looking at the NLST metachronous second lung primary lung cancers, also with a very good prognosis, often at early stage, and well worth looking for. There are reports from many countries on screening pilots and programs from all over the world. It's really getting going a lot in different individual pilots, although not that many full national programs, and not much mention of those countries that have decided against screening, notably France and Australia as being quite prominent. There was a focus very much on optimization and learning from the programs, and it's great to see lots and lots of data coming from these programs, and an excellent presentation from the Summit study by Sam Janes on the incidental findings problem. And then finally, I think one of the most important studies was this study, the Yorkshire Enhanced Stop Smoking Study, run by Rachel Murray from the University of Nottingham, in collaboration with the Yorkshire Lung Cancer Screening Trial. And the main aim of this study was to present this information to patients about their own lungs, showing their emphysema, and another panel showing their coronary artery calcification, and seeing if this added anything to a very intensive co-located smoking cessation service. The bottom line was that there was no real difference between the intervention and usual care, but usual care was very good. As you can see, the 7-day validated point prevalent abstinence was around 30% at 3 months, and this was continued until 12 months, a real improvement in potential outcomes from CT screening, and also quite cost effective. And the conclusion really was to ensure that from now on, there should be co-located, integrated, high-level smoking cessation. So I hope that's given you a flavour of what the World Lung Cancer Conference is about. As you can't really cover this in 15 minutes, but I hope that's been helpful.
Thank you very much, David. I'm just waiting for my camera to come back on. Maybe it's not going to. And you get gold marks for not going over time. So well done for that. So that's the aspects of screening covered. We're going to move on to surgery, and I welcome David Waller, also friend of BTOG, because everyone's a friend of BTOG, as far as I can tell. And David is a cardiothoracic surgeon at Bart's Hospital, formerly of Denfield, Leicester, which of course where BTOG originally came. And David's going to take us through changes and advances in surgery from World Lung and ESMO this year. David, the floor is yours. Thank you very much for dedicating your evening, or at least an hour of it, to us.
Thanks very much, Tom. Well, I have to say, 20 years since I was the founder member of BTOG with Ken O'Byrne. I'm glad to see it's still going strong and developing all these new technologies. Can I have the first slide, please? I can't see the slide, so I'll have to just assume that you're going at the same time. So I'm going to talk to you about a major advance in surgery, which was partly presented at the World Lung Meeting in Vienna, but also referred to a trial that was presented at the American Association of Thoracic Surgery. I can't see the slide, so I'm hoping you're showing the first slide, and you go on to the second slide. So the two studies I want to talk about are a randomized trial from Japan and a randomized trial from America, and both of these have challenged the assumed gold standard that lobectomy is the gold standard for stage 1 lung cancer. So we've got the Japanese JCOG study, which was a randomized trial looking at lobectomy versus segmentectomy for histologically proven, and this was done on intraoperative frozen section, stage T1N0 non-small cell lung cancer. And this was presented at the American Association of Thoracic Surgery and has subsequently been presented and published now in Lancet Oncology. And it showed significant benefit in terms of overall survival for segmentectomy compared to lobectomy. At the World Lung Cancer Meeting in Vienna, the Americans presented a similar trial, but this was lobectomy versus either segmentectomy or wedge resection. but it had a similar outcome, which showed non-inferiority for sublobar resection in, again, histologically proven non-small cell lung cancer with intraoperative frozen section that showed no evidence of lymph node metastases. Randomized trial randomizing patients with histologically proven non-small cell lung cancer with intraoperative frozen section analysis of lymph nodes that were confirmed to be stage 1A. Next slide. As you can see, there were 357 patients randomized to lobectomy, and just hit the next button. 20% of these were by thoracotomy, 80% by minimally invasive surgery, either VATS or robotic. Next button. And very, very importantly, 58% of the sublobar resections were by wedge resection. This is a very important point. So this was unlike the Japanese study, which was anatomical segmentectomy as the experimental group. This American study allowed the surgeon, providing they achieved adequate macroscopic margin, to perform a wedge resection. Next slide. So randomization was stratified by both tumor size, smoking status, and the histology, whether it's adeno or squamous. Next slide. The groups were similar. They had similar complications, similar air leak, and similar hospital mortality. Next slide. Now, going back to the Japanese group, they looked at the difference in lung function between sublobar and lobectomy, and there were similar findings in the American study. Both groups found a very small but significant benefit from segmentectomy. The important point being, it wasn't as large a benefit as they powered the study for. They assumed that doing a sublobar resection would preserve much more lung function, and it didn't. Next slide. In the Japanese study, they showed there was increased local recurrence after a sublobar resection. Next slide. However, in the American study, they didn't find that. They also found there was no difference in non-cancer related deaths. Interestingly, in the American study, over 50% of the recurrence was distant. And this is in stage 1 lung cancer, don't forget. Next slide. The Japanese study showed no difference in disease-free survival. And this is possibly because although there was a higher recurrence, and next button, and next button, it appeared that those who had disease recurrence were more able to be treated, both with radiotherapy, possibly ablation, and also salvage surgery. So despite higher recurrence, there was no difference in overall disease-free survival. Next slide. And similarly, in the American study, the CalGB, overall survival was no worse with a sublobar resection. If we look at the follow-up, it was extended to 7 years. So this was a long follow-up with these patients and showed no difference in disease-free survival. Next slide. Next slide, please. And next. So in the Japanese study, there was no difference in disease-free survival, but they actually showed a long-term benefit for sublobar segmentectomy in terms of overall survival. So there was not only, it was no worse than lobectomy, but long-term survival was better with more lung preserved. Next slide. And similarly, in the American study, the median follow-up of 7 years, the non-inferiority significance boundary was not crossed, so there was similar overall survival for sublobar resection, including wedge, against lobectomy. In fact, it was just tantalizingly showing that maybe the sublobar group had a better longer-term survival, but it didn't quite reach significance. Next button. And you see the hazard ratio was just suggesting there may well be survival benefit. Next slide. Okay, just hit the next button. And the next. So these two large randomized controlled trials that we've been waiting for nearly a decade showed that lobectomy is no longer the gold standard for histologically proven stage 1 non-small cell lung cancer. And in fact, it could be that it's actually detrimental to long-term survival. Next. And the staggering finding from the American study was that when possible, so if you could achieve a clear margin, a wedge resection and a nodal, together with nodal dissection to exclude N1 disease, was sufficient treatment for stage 1A non-small cell lung cancer. Now that was a stunning message, and it was one of the most significant findings in lung cancer surgery for probably 25 years since the lung cancer study group. Next, please. Of course, not all lesions are amenable to a wedge if they're more central, but in those patients, anatomical segmentectomy is at least as good as lobectomy, and in fact may have a longer term survival benefit. Next. Now, the question about whether a segmentectomy versus a wedge is required when a wedge is possible is being addressed now by the Japanese oncology group in the ANSWER trial, and that again will take several years to produce a result, but they're randomizing these resectable patients who are suitable for a wedge, either to wedge or segmentectomy. Next slide. Next. So it is possible now that to justify wedge resection as both a diagnostic and a therapeutic surgery for stage 1 lung cancer, which of course opens up the possibility of treating people with poor lung function. The days of doing a VATS wedge and a frozen section proceeding to lobectomy are gone. There's no need to do that. Next. And possibly there's no need to do a VATS lobectomy, because if it's a bigger tumor, it may not be suitable for VATS. If it's a smaller tumor, it can be treated by either a wedge or a segmentectomy now. So again, this is a massive change to the way we approach lung cancer. Next. And of course, for complex segmentectomy, so a more difficult unisegment resection of the lower lobe, for example, this is where robotic surgery has a big advantage over VATS. It's much more technically easier to conserve lung tissue using robotics, and it may well be a justification for a wider use of robotic thoracic surgery. Next. It may also be less necessary to confirm the preoperative diagnosis if we're only taking a wedge or a segment rather than a lobe. So it may change our approach to the suspicious lung nodule. Next. Of course, it calls into question the need for biopsy techniques such as navigational bronchoscopy if the lesion is otherwise resectable by a wedge. Next. Of course, it's assumed from these trials that it can't be applied to node-positive disease because they intentionally excluded node-positive disease in their protocols. Next. But it doesn't seem logical that removing more lung would be needed to treat nodal metastases, whereas we know there are targeted and systemic therapies that are intended for systemic spread. And finally, next. And of course, these findings really excited the clinical oncologists in the audience in Vienna, because they thought, well, stereotactic radiotherapy is similar to a wedge. So if you can treat it by wedge, then why not treat with radiotherapy? Well, that may be true, and that's certainly one of the discussion points we could address this evening. Thank you very much. Apologies for the technical problems.
Thank you very much. I think you did admirably, given the fact you couldn't see the slides. And I apologise unreservedly for failing to remember failing to mention that you were indeed a founder member of BTOG. So thank you very much. I've got so many questions regarding those few studies. I've been scribbling them down. If the audience have questions, please do pop them into your web browser. They will appear as if by magic on my screen, and I can ask them for you. So we're still in time, which is, I think, probably a BTOG webinar first. So I'm delighted to ask Yvonne Summers to come up to the stage. Yvonne is a medical oncologist at the Christie. And normally when we come to the early non-small cell lung cancer talk, it's a bit boring and it's, one or two talks. But early stage lung cancer is the poster boy or girl, poster person of lung cancer conferences. There is so much going on in the adjuvant and the neoadjuvant setting. And Yvonne has the slightly unenviable task of trying to distill that into just 15 minutes without repetition, hesitation, or deviation. Yvonne, the floor is yours, and I hope you can see your slides.
Thanks, Tom. And I make no apologies for making this very much a medical oncologist's view of early stage disease. And I hope very much that I can stick to the 15 minutes, but I don't think I'm going to make any promises here. And I would also say that I'm absolutely going to be focusing on the big randomized studies, which are going to potentially impact most on clinical practice, although clearly there were a number of non-randomized phase 2 studies which had very interesting data in this arena also. Those are my disclosures. So the first study to discuss is the 4-year update of the ADAURA study. So just to remind you, this is the adjuvant osimertinib study for patients with completely resected stage 1B to 3A disease. Patients could have chemotherapy if it was applicable to them. And they were randomized in a 1-to-1 fashion to either receive osimertinib for 3 years or placebo for 3 years, with the primary endpoints being disease-free survival in the stage 2 and stage 3 patients, and then the key secondary endpoints relating to disease-free survival in the overall population and overall survival, and some health-related quality of life measures. It was important to note that CNS metastases and CNS recurrence was a key area of interest. And at this time point, all patients within the study have had the opportunity to have 3 years of treatment. But it's also key to report that although this is 4 years follow-up, the study is still far from mature. So if we look at the disease-free survival curves, the curve on the top left of your screen is the original data that was presented at ASCO 2 years ago. And you can see those really impressive, widely spaced curves for the stage 2 and stage 3 population with a hazard ratio of 0.17. If we now look to the top right of the screen, you can see those updated curves, which look remarkably similar. So now with 4 years follow-up, you can see that for the first 3 to 4 years, those curves are very similar, with the disease-free survival, the median disease-free survival being 21.9 months in the placebo arm, and 65.8 months in those on the osimertinib arm for the patients with stage 2 to stage 3 disease, and a hazard ratio of 0.23. So the disease-free survival benefit clearly been confirmed with further maturity. And if you look at the subgroups on the bottom of the slide, you can see that that benefit is consistent across all of the subgroups that were looked at. And in particular, you can see for those that had adjuvant chemotherapy or otherwise still benefit maintained. So a clear benefit across the entire population. However, if we come to look at the different stages, stage 1B, 2 and 3, you can see that the curves are slightly different. So for the stage 1B patients, the 4-year disease-free survival rate, 80% for those receiving Aussie, 59% for those receiving placebo, with a hazard ratio of 0.41. So even with stage 1B disease, a nearly 60% reduction in the risk of recurrence for osimertinib versus placebo. And with the curves of the stage 2 and stage 3 that you can see there, with the hazard ratios 0.34 for stage 2 and 0.2 for stage 3A. However, I think it is important to look at the shape of the curves. So you can see for the stage 1B curve, the osimertinib arm does seem to be plateauing. But for those with the stage 2 and the stage 3, at the 36-month point, you can see that perhaps that curve is beginning to dip a little. And remember, 36 months is the point at which the osimertinib stops. So I think there is a key question for us about what is happening when the osimertinib stops. Is there more recurrence occurring at that point? And what is the follow-up that we do, particularly in terms of screening with scans from 3 months onwards? There's some clinical questions that we have to think about with regard to the patients that are treated, but clearly the benefit is very substantial. And if you look particularly in those with CNS disease, you can see that bottom curve at the bottom, that the rates of CNS recurrence are actually much smaller for those with osimertinib compared to those on placebo, with a hazard ratio of 0.24. And in terms of the pattern of disease recurrence, you can see from that bottom right-hand graph that the patients are recurring in lung, lymph nodes and CNS, with the rates of CNS recurrence, of course, less for those on osimertinib compared to those receiving placebo. So some real recognition that the benefits that were originally reported with adjuvant osimertinib have been persistent at 4 years follow-up. The studies are still not quite as mature as we'd like them to be. We have some questions about overall survival and what's going to happen with these patients with longer follow-up. But I think there's still no doubt in my mind that osimertinib is a standard of care for patients with stage 1B to 3 completely resected non-small cell lung cancer with EGF mutations. There are some questions about what are the follow-up for those patients. And of course, how we screen for CNS disease, but the changes that we made to our practice are consistent and should continue. So moving from EGFR to patients with resected non-small cell lung cancer in the immunotherapy setting, we saw at ESMO an update of overall survival from IMPER-010. So remember, this is patients with resected, completely resected stage 1B to 3A non-small cell lung cancer. All of the patients in IMPER-010 had had adjuvant chemotherapy and were then randomized in a 1-to-1 fashion to receive 1 year of atezolizumab or best supportive care. And we'd previously seen data presented on disease-free survival. But here we see data presented on overall survival and in particular some key subgroups. So of course we have access to adjuvant atezolizumab in England for patients with completely resected stage 2 to stage 3 disease with PD-L1 of greater than 50%. And you can see the overall survival curve on the right-hand side for that group that we're clinically treating at the moment. The median overall survival has not been reached in either arm, but you can see that the 3-year time point, the median overall survival being nearly 90% for those receiving adjuvant atezolizumab compared to 77% in those in the placebo arm. And those curves really being maintained out to the 60 months that you can see. And the hazard ratio 0.42. For those with PD-L1 1% or more, the hazard ratio 0.71, so that little bit higher and crossing 1. So again, these studies are still quite immature, but reassuring to see that the benefit in that greater than 50% stage 2 to stage 3 disease being demonstrated in terms of overall survival with further follow-up. And in terms of toxicity, you can see that there were no great surprises in terms of adverse event reporting. And I thought what was interesting was that about 12% of patients receiving atezolizumab required corticosteroids, which certainly reflects our clinical practice that there is that sort of rate of immune-related adverse events which require intervention. So no new safety signals and a clear trend to improvement in overall survival, particularly in the group that we are clinically using atezolizumab in clinical practice at present. So moving from atezolizumab to the PEARL study, which many of us participated in England and the UK. So this is adjuvant pembrolizumab, very similar study in that it's completely resected patients with non-small cell lung cancer, stage 1B to 3A. Any PD-L1 expression. Patients in this study did not need to have adjuvant chemotherapy, so a slight difference to the IMPER-010 study. And patients were again randomized to either receive 1 year of pembro or placebo, with the primary and secondary endpoints that you can see at the bottom of the slide. Now, the key area of interest at the presentation at ESMO was the outcomes in terms of disease-free survival by subgroup, because there had been at the previous presentation not quite the consistent story that we'd seen with the IMPER-010 study of increasing benefit according to PD-L1. And you can see from the Kaplan-Meier curves, those curves are split, but for the PD-L1 greater than 50%, hazard ratio is 0.82. And the confidence intervals unfortunately cross 1. There was a lot of analysis of the details of each of the subgroup. And if I can draw your attention to the fact that if you look at the placebo group in the study, so the blue line, you can see that at the time points depicted, so the 12, 24, and 36 months, the timelines for the placebo, the percentages for the placebo are higher. So 74, 67, 57 compared to, for example, in the 1 to 49%, 62, 54, 44. So the placebo arm seems to be performing better than we would anticipate for the PD-L1 greater than 50%. And in the exploration of the subgroups, it became clear that the patients on the placebo arm in that group, there were many more of them who were N0. So there's probably an imbalance, which is resulting in a higher performance of the placebo arm for the greater than 50%, rather than it being a genuine lack of benefit in that patient group. And again, when we come to look at the adverse event reporting for the study, very similar to the results that we've seen previously, and about 10%, 10 to 12% of patients having discontinuation of study drugs. So fairly typical for those that we've seen across the immunotherapy studies, and no new concerns. So moving from the adjuvant setting to the neoadjuvant setting, the next study that I'd like to discuss is NADIM-2. So this is neoadjuvant. So this is for patients with potentially resectable stage 3 non-small cell lung cancer without EGFR or ALK mutations. So dissimilar in that it's only stage 3, so not the stage 1B and stage 2 that we've seen with the other adjuvant studies that we've discussed so far. And patients were randomized in this study, it's a randomized phase 2 study in a 2-to-1 fashion, to either receive a combination of chemotherapy and immunotherapy with nivolumab and carbotaxol versus carbotaxol alone, each for 3 cycles. Then the patients went on to receive surgery, and for the patients on the chemoimmunotherapy arm, they also received 6 months of immunotherapy with nivolumab. And it's important to point that out because the previous study that we had reported earlier on this year at AACR, Checkmate 816, had a very similar design, although it wasn't only in stage 3 patients, but there was no adjuvant immunotherapy in that study. So some key differences, but really the study giving us further information in this very important neoadjuvant arena. So getting to the key results, you can see the progression-free survival in the top left-hand curve, and you can see those curves are very widely split, with an over 20% difference in the 24-month progression-free survival, with a hazard ratio of 0.48. Progression-free survival 18.3 months for those stage 3 patients on the chemotherapy arm, but not reached for those on the chemoimmunotherapy arm. And really importantly, we've got overall survival data here. So of course, it not mature yet, so the median has not been reached for either the chemotherapy or the chemoimmunotherapy arm, but those curves very widely split and hazard ratio 0.4. And importantly, in any neoadjuvant study, when we come to consider the surgical outcomes, you can see that the R0 rate for patients receiving chemoimmunotherapy was much higher than those receiving chemotherapy alone. So 92% for chemoimmunotherapy versus only 65% for chemotherapy alone. Only 7% of patients on the chemotherapy immunotherapy did not get to definitive surgery, compared to about 30% of patients on the chemotherapy arm. And you can see that more patients were downstaged with chemoimmunotherapy, 69% of patients being downstage compared to only 40% with chemotherapy. So important study, really validating the results that we saw already this year from Checkmate 816, meaning that chemoimmunotherapy really is a game changer for patients with non-small cell lung cancer, and is likely to start to change the treatment pathways for our patients in the very near future. Of course, we don't have approval for these regimens just yet, but I think it's probably not long before that's going to happen. So the final study that I'm just going to touch on in the last minute is a negative study, but I think it's a really important study for us to update ourselves on the outcomes from. So many of you will have been involved in canopy studies, both in the adjuvant setting and also in the metastatic setting. The two metastatic studies that have reported previously, unfortunately, were negative, but this is the adjuvant study, which was again looking at patients with resected stage 2A to 3B and non-small cell lung cancer in this case, and patients were randomized having had chemotherapy or not to either receive canakinumab or placebo, essentially for 1 year. And you can see from that disease-free survival curve at the bottom, unfortunately, despite having shown some really impressive results in some of the cardiovascular studies in terms of the incidence of lung cancer, unfortunately, those results have not related to benefits for our patients in the adjuvant setting, or indeed as previous studies have shown in the metastatic setting. Of course, Charlie Saunton did discuss some very interesting data on the development of lung cancer and the initiation promotion model, and it may well be that canakinumab, although it's not important in metastatic in the adjuvant setting, there may be some other roles for that molecule in prevention. So take-home messages. Adjuvant osimertinib is here to stay. It's standard of care for us. We still have some relatively immature data, and we need to be thinking about how we follow our patients up, particularly with regard to scanning, because there are some changes in those curves from the 3-year time point when the drug stops. So it's here to stay, and it certainly gives us some clinically meaningful benefits in terms of disease relapse. Adjuvant atezolizumab in patients following chemotherapy for stage 2 and stage 3 disease with high PD-L1 has shown some really impressive improvements in disease-free survival. Median overall survival not yet reached, but is the standard of care. The PEARL study has demonstrated similar disease-free survival benefits across the PD-L1 groups, not reaching statistical significance in the PD-L1 high, but probably due to overperformance of the placebo arm. And in terms of neoadjuvant treatment, the NADIM-2 study validating the study results that we saw from Checkmate on 816 earlier on in the year, and really identifying this as a key area of treatment in the future. And finally, canakinumab for patients with completely resected non-small cell lung cancer does not improve outcomes. And I think I'm just at the 15 minutes, so thank you very much for your attention.
That's you've kept up the gold winning position that we are absolutely bang on 15 minutes. Thank you very much indeed. Got various questions coming through. To remind people, if you want to ask a question, put it in the browser. If that's not working, I don't know, maybe try the chat. I don't know. But we love questions. So we're going to move on. At least I'm going to move on to my bit. I'm not going to introduce myself because I've done that already. That's a picture of my hospital. A London bus for you. So I'm going to talk about ESMO and wild lung, advanced non-small cell lung cancer. I'm actually just going to talk about ESMO. I'm not going to do anything from wild lung because I've only picked out 4 different studies, and I think it's best to know, as my colleagues have shown, that to know a lot about a small number of subjects, it's better to know a little about lots of them. Here are my disclosures. So here are my fantastic 4. We've got Ipsos, UK-led study, plenary session on the last day, Professor Ming Li was waving the flag, and it's brilliant, metaphorically. We got Codebreak 200 for sotorasib and KRAS G12C, the big phase 3 study, also in the plenary session. We've got Disciple, just a really interesting academic study from France, which I think asks so many questions, doesn't quite answer them. And then we've got Insight 2, which gives us insight into what we should do when osimertinib stops working. So the first one is Ipsos. As I say, this is a study presented by Professor Ming Li, again, friend of BTOG, regular attender, in a really important patient group. These are the guys in non-small cell lung cancer who aren't well enough to have platinum-based chemo. And any of us who sit in a lung oncology clinic will see a very large number of patients in this situation. So they're platinum ineligible either because they're PS2 or 3, or they're better PS, but there is a reason why, because of comorbidities, they cannot have a platinum. And they're randomized either to atezolizumab, that PD-L1 inhibitor in blue at the top, or chemo in red. And the two you could use was either vinorelbine or gemcitabine. And those really continued until progressive disease. And the primary endpoint was overall survival, really relevant in this patient group. So what is the headline news? The headline news in this study is that if you are platinum ineligible, well, overall survival is better if you get single agent atezolizumab compared to chemotherapy. Tezo in the blue, chemo in the red. You'll see at the very beginning, around the 3-month mark, there is a crossover of lines. You see the chemo lines are a wee bit higher. We've seen this quite a lot with immunotherapy versus chemotherapy trials. So we do always have to be careful when giving immunotherapy, because at the very beginning, in some patients, chemo is better. But beyond that, atezo wins with a hazard ratio of 0.78. In other words, a 28% reduction in the chances of death. Secondary endpoint in the bottom right-hand corner there, overall response rate was twice in that of chemotherapy in the atezo arm, so almost 17% with atezo. And the duration of response, again, double in the immuno compared to chemo. So that is really interesting data, I think. Can we pick out one group who does better or not better? The answer is no, not really. If you run your eyes down the forest plot here, you will see that all the little triangles are just to the left, the dotted line, meaning in every patient group, by and large, there is benefit of atezo over chemo. And the ones I'll particularly draw your eye to is the bottom right-hand corner, where it says PD-L1. This is not PD-L1 dependent. The PD-L1 negatives deriving as much benefit as your PD-L1 positives, which I think is a surprise. Ditto presence of brain metastases towards the top of the right-hand side. And no difference in histology, bottom left, and no difference according to performance status. So across the board, the benefit is there in the subgroups. Obviously, what's really important here is going to be quality of life. And there was a lot of quality of life data shown. This is not all of it. I've just happened to pick out one or two. And we can see that atezolizumab in blue, you have an improvement in social functioning on the right, cognitive function on the left, and general role functioning in the top left compared to chemotherapy. And I think anyone who's thrown around chemotherapy will know that that's not a huge surprise. So not only are we getting that overall survival benefit, you're actually also getting quality of life benefit. And that's going to be essential, because let's remind ourselves, these are PS2-3 patients, or those platinum ineligible, so almost certainly got other medical comorbidities. So I think this is fascinating. What are my thoughts on Ipsos? My thoughts are, this is a very relevant patient group. We see it all the time. It's a patient group not represented in standard clinical trials. It's a pragmatic UK study. I absolutely applaud Ming Li for leading this. What a great idea. This is a kind of study we do really well. It met its primary endpoint, big thing, although chemotherapy does do better initially. There are some things for us to be mindful of. The contraindication to platinum, a little bit unclear still. I mean, I think we want to see the paper. What do we really mean by platinum ineligible? Are the chemotherapies used really the best control arm? So you'll notice that, for example, pemetrexed wasn't included in there. Do we feel that VIN and GEM are the best ones? There was, of course, when you think about it, of course, a patient bias towards PD-L1 negatives and lows. And that's, I think, because the PD-L1 highs were getting immunotherapy anyway. And we have to think about cost. So vinorelbine, gemcitabine, cheap as chips, atezolizumab, not as cheap as chips. So although we can see an overall survival benefit and a quality of life benefit, we have to think about the cost implications of that. But I thought this was a really good study. And although it may not necessarily immediately change practice, it does make us think about how we treat our less well patients. The next one is CodeBreak 200. A lot of excitement about this, a lot of hype about it. This is the phase 3 registration study of sotorasib, KRAS inhibitor for G12C patients. You may well be using it already based on CodeBreak 100. That's a phase 2 study. This is the phase 3 randomized study, the first randomized data. To remind you, this is going to be after chemo and or immuno. But you have to have had chemo and immuno. You can't have had only one of those. No active brain mets, and randomized 1-to-1 between sotorasib and the old enemy docetaxel. Just have a look at the bottom where I put in the red exclamation marks. So there was a reduced enrollment during this from 650 to 330 patients by the regulators, and crossover was permitted. So this does interfere with the results, because almost halfway through the study, suddenly things get changed. We've got to bear that in mind when we're thinking about the results. So this was the first data put up, which is the improvement in primary endpoint, which is progression-free survival. And I think this probably didn't surprise that many people, because we've seen improvement in progression-free survival in the phase 2 data. So you can see there that the hazard ratio is 0.66. So that's a 34% reduction in the chances of progression. And you can see an improvement in the median there, which is less important, less impressive, I'm so sorry. They've been a little bit unlucky where the curves come together, but maybe what might be more useful actually, look at that 12-month landmark, 10% versus almost 25% with sotorasib. So an improvement in primary endpoint of progression-free survival. But this to me was perhaps a more relevant slide, or a more impactful slide, which is there was not an improvement in overall survival. And this did get a little bit glossed over in it. And I always have a little bit of concern when that's the case. There are a couple of big caveats. Number one, because of that change in patient numbers, this was actually underpowered to achieve, or sorry, to report on, to detect a change in overall survival. And I absolutely get that. Although if you look at the lines there, I don't think there's anything between them. The other thing to say is there was crossover allowed, and I put on the right-hand side there, I've told you about the crossovers there. So there was a bit of crossover. Of course, crossover is going to hide an overall survival benefit. And then I've also told you the number of patients in the bottom right there who have crossed over, 26%, and those who received a G12 inhibitor anyway, another 7.5%. But I think this overall survival, or lack of overall survival benefit, was to me surprising and was certainly disappointing. What about adverse events and quality of life? Well, it was reported as being well tolerated. I don't think I'd agree with that. I think a 33% grade 3 or more toxicity, I don't think it's unmanageable, but I think we have to recognize sotorasib as a drug where we do have to look at GI and liver toxicity and dose adjust accordingly. And I don't think that's a major issue. You can see the dose interruptions and dose reductions underneath my red box there. But I think to describe it as well tolerated is probably pushing it a bit far. That being said, very importantly, if we look at global health status, physical functioning, breathlessness, you can see that sotorasib is better than docetaxel. And to me, that's a really key piece of data, because this is a second or third line treatment. Quality of life is really, really important. So yes, it does have side effects, but I think what we can see here is that the impact of those is less on the patient, and the patient has a better quality of life. So my thoughts are, well, the good news is confirmatory phase 3 study, it has met its primary endpoint, and I think it does solidify sotorasib as currently the standard of care for relapsed G12C only KRAS mutated lung cancer when patients have had chemo and immunotherapy. But there are some caveats, and those caveats are the treatment-related adverse events, predominantly GI and liver. I think docetaxel is a suboptimal control arm. I mean, it's the one they have to use because of the regulatory issues, but really the control arm in the UK would be docetaxel and nintedanib, and in places like North America, you would put in ramucirumab along with docetaxel. So I think the control arm is a bit suboptimal. Those changes in sample size and crossover, they complicated things, and I think the lack of the overall survival is problematic. So I think it's a little bit disappointing. I think it suggests modest clinical activity, and we wait subset data, and I look forward to the combination studies with other agents, which are increasingly important now. Disciple is the third study. This is a fantastic French study, an academic study, looking at patients who have advanced non-small cell lung cancer and they receive nivolumab, ipilimumab. And you're thinking, hang on, Tom, why are you talking about this? We don't use this, but bear with me. These guys get 6 months of niv-ipi, and after 6 months, with their disease controlled, if they are still controlled, they're randomized to either continue niv-ipi until progression or to stop and observe. Yes, this is a randomized study looking at how long do you give immunotherapy for. That's why it's an academic study. What you can see looking at the treatment-related adverse events in the continuation arm in red on the left, you can see the immune-related adverse events are significantly higher than the patients who got 6 months of treatment, stopped, and then restarted the immunotherapy when they progressed, the stop and go arm. So your adverse events are better. But what's really interesting is your progression-free survival is better. And there's a hint of overall survival on the right as being better as well. Yes, that's right. If you get 6 months of combination immunostop and then restart when you progress, your progression-free survival is better, and overall survival may well be better than patients who have it continuously. Now, there was a big problem with this study, which is that niv-ipi is not licensed in Europe, and therefore the pharmaceutical company who was funding the study, sponsoring the study, I'm so sorry, withdrew from the study because of that licensing issue. So the study stopped early, and we don't have a clear answer about PFS and OS. But I think it's fascinating because it's an exemplar of academic studies. Commercial studies won't do this. There is a strong signal within the findings, which is that shorter treatment and restart, and it's not detrimental. In fact, it's safer, and it glimpses the stop-start approach. But that early termination is a problem, and we do need a confirmatory phase 3 study with a licensed combination. And guess what? Our French colleagues are ahead of the game. They've got the DIAL study going, which basically is the same as this, but with pem platinum, as we are probably more familiar with. So watch out for that study. I think this is fascinating. My last study I'm going to discuss is INSIGHT 2. This is EGFR mutated lung cancer, patients on first-line osimertinib who develop MET amplification, which you can see in the top, is about 15 to 30% of patients progressing on osimertinib. They have the MET amplification checked either by NGS or FISH, and if they have it, they get tepotinib added in to their osimertinib. You can ignore the tepotinib monotherapy arm. The answer is it doesn't work. So TPO plus Osi in this single arm phase 2 study. The primary outcome is response rate, and we're waiting for survival data. I don't have any survival data for you, but look at the response rate there on the people on follow-up more than 9 months. Overall response rate is 54%. And I think that shows a really interesting suggestion of clinical activity. For those of us who've been giving tepotinib for MET exon 14 skipping, which is now available in the UK, you'll be familiar with the peripheral edema and the diarrhea that you get with this drug. And that's what you see with the TPO and Osi combination. And there doesn't appear to be a significant additional and complicated side effect profile when you add TPO to Osi. So, interesting, amongst the first data targeting first-line Osi resistance, 54% response rate. Yeah, I know it's single arm. I know we need more patients. I know we need more data. This suggests to me there's activity, and it's practical and feasible. I can imagine adding in the tepotinib to my osimertinib, where some of the other approaches at the moment seem to be quite a long way away from where we are. But we do need to have survival data, progression-free survival, overall survival. I think that will be coming. We need randomized data, or do we? Do we really want to take on a phase 3 study? Do we really want to wait months, years to get the answer? And the other thing we can note is that giving tepotinib alone is not an active combination. And that is the last of my slides. So I'm going to move on to here, and I'm going to look at the questions that have come in. And I'm going to bring my other colleagues back into the room, metaphorically. Okay, so without taking a breath, I'm going to talk to David. I hope David Baldwin, I hope you're there. Your camera's off, so I can't see you. I hope you're kind of poised. Just wait. Yeah, there you are. Excellent. So David, we're going to start with you because you went first in the first place. Question about family history in lung cancer. So not something we focus on very much in lung cancer. We ask a lot of it as oncologists in breast cancer and ovarian cancer. Given the Taiwanese study, what's your view on family history in lung cancer? Should we be looking at it differently? What do we already know about family history in lung cancer?
Well, it's not a surprise actually, in that most of the risk prediction models that we look at that have look at family history, the family history is always an independent factor. So it's not strong, and you have to be really careful about confounding due to smoking when you're looking at it as an independent risk factor, but it is there. And the big problem with any data collection when you're informing risk models is the extent to which the data is collected accurately or not. And certainly even then, some of the risk prediction models, what the LLP version 2 and 3 as one example shows that, you know, family history is included in that. So I think it's there. It would probably be even better if you took a really careful history, and therefore maybe the Taiwanese data does have rather better family history data, but was difficult to get that out of their studies. So it's not surprising. I mean, I think it is something we should be aware of. As I said, you've got to be careful because you have a family of people who've maybe come from a socially deprived group, and lots of smoking in the family, lots of secondhand tobacco smoke, all of those things going on together. So it's a little bit careful, be a bit careful about this. But to be honest with you, most of the multivariable models that I've seen that have looked at this in detail have shown that that's an independent factor.
Thank you very much. I'm going to move on to David Wallaby. I'm going to come back to you, David Baldwin. David, obvious question for the Japanese and American studies, lots of people are asking is, does it change practice? Directed at you, does it change your practice? In your next week's MDT, someone comes in stage 1A lung cancer, are you going to be altering your recommendation for the patient's treatment? And if so, why? And if not, why?
I've been doing segmentectomy for stage 1 lung cancer for 15 years. So no, we do 85% of my lung cancer resections are robotic segmentectomies. So that won't change. What I have now already, the first list when I got back from Vienna, I did 2 robotic segmentectomies and 1 robotic wedge resection. Look, you ask for evidence, you want evidence-based medicine. The problem is with positive trials, if it contradicts what you believe, you find reasons not to do it. This is a game changer. Yeah. This really is. It will hit surgeons. They've taken a long time to learn to do vasculobectomy. They think they're very clever. Aren't we fantastic? Oh dear, now we've got to learn something else. This will be the problem, that surgeons will find reasons to do what they like doing. And it's difficult to do a segmentectomy. It's not difficult to do a wedge. And this is where, that's, I think, the big message, is that we can do therapeutic wedges now, not just in people with poor lung function. And that's a big change. That is a game changer. That if you think about it, a lot of these people have had VATS frozen section, then gone on to a lobectomy. Well, they don't need that.
Excellent. I like that. Again, I'm going to come back to you in a minute. Yvonne, I'm going to move on to Adora. It's a question from me, actually. I thought those DFS curves were coming together, and I thought they were coming together at 3 years. That says to me you're not preventing anything. You're just delaying it. Does that make you more or less likely to give osimertinib adjuvantly if you're concerned you're just delaying and not preventing?
Yeah, I think it's a good point. And I think when you look at Sanjay, as you know, did a lovely discussion at ESMO and had some nice lines drawn on those curves, which particularly for the stage 2 and stage 3s did look like the gradient changed at 3 years when the osimertinib stopped. So there is clearly a concern about, how much drug is enough? Is 3 years enough? Do we need to be, are we in the situation that we were with breast cancer many years ago, when actually adjuvant hormones then had to be extended in duration as the data came through? So I think there is a question about how much drug is enough. But then the second part of the question, which is probably the more important part, is it the right thing to give adjuvant osimertinib? Well, yes, it is. I think if you ask any patient whether they would like to have their disease-free survival curve split like that, yes, they would. They don't want their cancer to come back, and they don't want to get brain metastases. So I think there's some really clear reasons why, yes, the treatment is the right thing. We have some issues around what is actually happening with longer follow-up. Are those curves coming together? Does this mean that we need to be doing something different? Does our follow-up need to be more nuanced at that stopping point, rather than us doing scans 6 monthly or 12 monthly? Is there an argument, particularly for those higher stage patients, to be having really much more careful follow-up between years 3 and years 5? That's a question that I think we have to be asking ourselves now. And then there's the bigger question about, should we be doing treatment for longer?
Thank you. David Baldwin, back to you about the Taiwanese study. Question here about the detection rate, 2.6%, which seems so high. What are your thoughts on that? I mean, is this reflecting the unique patient population there? Is it reflecting lung cancer is always going to be there? We just don't realize, regardless of the patient you look at. What's your take on it compared to the screening studies in the smoking populations that we've seen so far?
So I think it's really difficult without knowing the detail of what is actually going on, because on the one hand, it could be that they are identifying potentially lethal disease very early on through a combination of the biology of the cancer being slightly less aggressive, and therefore a greater proportion of the screen detected cancers being indolent, but nevertheless still lethal in the long term. Or it could be that this is all overdiagnosis. And that is the major concern, because when you see people classifying their resections as cancer when we wouldn't actually say they were cancers, then that is clearly a difference in the way we would report things in a study. And so I mean, I wished I knew the answer to this. What I was very impressed with was the Taiwanese population data, which looked at the diagnosis rate amongst early stage disease versus the diagnosis rate of late stage disease. And screening works. One of the surrogates, it's not a very good surrogate, but one of the surrogates for screening efficacy is a reduction in late stage disease. It's not a complete surrogate, and that's one of the problems with the potential problems with the Galleri test, in fact. But actually, we don't see a reduction in late stage disease in the Taiwanese population, despite the screening activity that's been going on, which does make you worry about overdiagnosis. So I really think that time will tell. The studies will be ongoing. The bigger national screening program will also be important to evaluate. And I think it's really about what we really believe is going on. And I think people like David, who've maybe gone to see the operating practice of these patients on these patients, and what they're actually taking out is probably most relevant. I think the actual on the ground evidence, and I've heard from a number of different surgeons about what they think about that.
Thank you. David, you were mentioning, you were mentioning earlier segmentectomy. You've been doing a lot of those. I think you said in the Japanese study it was found to be less advantageous than people thought in terms of lung function. Is that what you're saying? Is that a surprise? Were you caught out by that, or did it kind of reinforce what you thought? And if so, why do you think it was less advantageous than people hoped?
Well, you could base it on the incorrect assumption that all of the lung segments have equal function, which of course they don't. And for 25 years, we've been resecting emphysematous lung tissue to improve lung function. And the more emphysematous lung tissue you take out, the better the lung function. Now, surprisingly, the Japanese, I raised this in one international meeting with Asamura, and they hadn't thought about it because they don't do volume reduction surgery in Japan. But I suspect, obviously, if you take the whole of the right upper lobe out and it's emphysematous, you get a better FEV1 improvement than just taking out segment 3, for example, and leaving the emphysematous segments in. So to qualify that, I wouldn't always do a segmentectomy. My aim is to preserve as much functioning lung tissue as possible whilst adhering to oncological principles. So, I wouldn't do a unisegment of the right upper lobe if it was all emphysematous. I'd do an upper lobectomy. So I'm not sure that lung function is a very good parameter. It's possibly more important how much vascular tissue you preserve, and certainly in the lower lobe. And you take out too much of the lower lobe and you will increase the pulmonary vascular resistance. You send the people into heart failure. Eventually they've all got COPD and more of their functions in the lower lobe. So it may be that the best use of segmentectomy is in lower lobe disease because that's better to preserve. Whereas, as I say, right upper lobe, you're probably better off without it if you've got emphysema.
Yeah.
Wedge resection is different, of course. Wedge, you can do wedge on anybody, really. This is the big thing that when you get in the MD2, all these patients not fit for a lobectomy, good. We just want to do a wedge. Now that could change. That's a big game changer.
But make sure you take your nodes out. Don't just do a wedge.
Well, yes, and that is very important. It can't be just a quick and dirty wedge. You've got to do a staging operation at the same time because they may benefit. These fancy drugs you give in adjuvant settings, all these funny limamabs and all those sort of drugs. Well,
Talking about which,
to know if you've got no positive disease. So there you are.
Talking about which, Dr. Summers, nothing's ever done quick and dirty at the Christie. I'm sure it's done meticulously and cleanly. The Canopy A study. Bad luck or bad science? We've had a series of Canopy studies. They're all negative, very disappointing. Some people say it should never have been done. It was on a premise of a chance finding in a cardiac study. And other people say you had to look into it. You had this study showing in cardiac, if you gave canakinumab, many fewer people developed lung cancer. What's your take? Bad luck or bad science?
So I think it's bad science, isn't it? Well, my view is that it's bad science, but you could not ignore the data from those cardiovascular studies. It was really impressive data. I guess the point is that we went a step too far without understanding the basic science. And I'm not sure that it's completely died. Are we going to see some lung cancer prevention studies emerging at some point? I don't know, but that might be the role for it.
Very much. Well, look, we are a minute from time, and I'd just like to thank all my excellent speakers, David Baldwin, David Waller, and Yvonne Summers, for joining me and giving their time. Just say to people, when you get asked to do these talks by BTOG, it's the email that's a bit of a heart sink because you've got to go to the meeting, and then you've got to try to remember what on earth you heard, and then pull it all together. So it is no mean feat, and I'm very grateful for them doing it. I just wonder if our AV colleagues could put up our closing slide, because I wanted to tell people about BTOG 2023, which has been announced today, is in April next year, and it's in Belfast. So we have a new location, which is very exciting. And I'd encourage you to have a look on the website and obviously book out the whole of April in preparation for BTOG 2023. Because it's going to be very exciting. Before that, however, we've got other in-person events. We have the BTOG Non-Smoking Lung Cancer Central Update. This is in collaboration with the Ruth Strauss Foundation. And this is something we're very excited about. It's in a couple of weeks' time, which I need to pay attention to because I'm going to be speaking at it, so I better start writing my slides, at Lincoln's Inn Field. And we're delighted to work with our friends and colleagues at Ruth Strauss Foundation. And then in early December, just before Christmas, Riaz Shah is, if you just get back one slide, if that's okay. Riaz Shah is leading on our mesothelioma essential update with Mesothelioma UK and our friends there. That's the Cavendish Conference Centre in London. There is so much going on in mesothelioma at the moment that I think this is such a pertinent study. So moving on to our last slide, if that's okay, again, to remind you of the excitement of the BTOG 2023. I'll just move the slide forward. There we go, in Belfast at the International Conference Centre. There, we've known about it for a while, but we weren't allowed to say anything. And I've had a look at the map of the ICC. It looks absolutely fantastic. And I think this will be the high point of 2023, if I may say. So thank you very much, everyone, for joining me. Thank you very much again to my speakers and to our sponsors of today's event. And we look forward to catching up with you, hopefully, at our next webinars. Thank you very much.